Well, while everybody's being seated, I'm going to ask you to pay attention to the pictures that are up behind us. Um, Here we go, right, lefting. I'm going to get into trouble. So the picture on the upper left is a young woman who was diagnosed with a HER2 overexpressing breast cancer at the age of 24. And she was looking forward to her wedding, but she needed to be treated first because of this very aggressive subtype breast cancer, which we're going to discuss in the present session. I treated her, and you can see that she lost all of her hair, but she also got rid of all of her breast cancer. When she went to surgery, she had a CR, which means we couldn't find any cancer cells in her breast or her lymph nodes. Applaud on that one. She got married, and she refused to wear a wig. And you can see her here in her bridal gown with her bridal party. Very excited. And she went on an anti-estrogen therapy after she completed her anti-HER2 antibodies. And she said to me what all young women say who have dreams and magic in front of them and a husband that they're in love with, a partner they're in love with. When can I stop these pills to have a baby? Ouch. You know, it's one thing that we've all encountered in our practices, and For the Promise trial gave us some support stating that, yes, patients who are estrogen positive, who have completed 2.5 to 3 years of their endocrine therapy, can take a pause, have a baby safely, and then resume their endocrine therapy. And I will tell you that since that publication, several babies have been born, and on the, I guess that's the right, you can see that her husband is holding a young child. They named her middle name Maria, which made me cry. And then I said to her, well, you're living in Maine now. You have to see the local medical oncologist to resume your tamoxifen. And she said to me very quickly, I'm pregnant. Please let me have another baby. And there you see her second little baby, who's a lovely little girl. And there is life. There's life. And there's a drawing right underneath that I think is just, when I first looked at it, it kind of knocked me backwards. When you look at this piece of artwork, I've got to be careful not to speak to the painting is called And So It Goes, and it's by Drew Lost. Drew, are you in the audience? Can you stand up safely? This is Drew. Drew came to me less than a year ago when she moved up to this part of the world from Memorial Sloan Kettering Cancer Center. We said it was okay to talk about this. She is 27 years old, or are you an old lady of 28? Okay, an old lady of 28 with metastatic breast cancer to her bony skeleton and treatable. Get that? Treatable. And when this was painted, she had just found out that she had advanced disease, and this is how she felt. And I thought it was such an outstanding piece of work that I asked for her permission to, I think it's on the back of the program here. Here it is. Okay. And I thought it was very inspiring because where we all fall short, I say it with all respect to people that I love on the stage, where I fall short is that, yes, we're compassionate, we're caring, we want to do the best for our patients, we want to listen to their voices, we want them to hear our voices, but in a half hour, we have a new patient. And now redirecting. And then we go home and we have our own life issues and we're redirecting. But all of that is going on in the patient that we saw earlier that day. And we have to find a way to make the beauty of that the beauty of their lives. And Drew, thank you, darling. All right. Thank you. So with that, we're going to move to the second panel discussion. I got emotional. My mother told me I was not meant to do this for a living. She said you should be delivering babies. I said, but then I would have to take them home. So it doesn't make any sense. So I'm going to start by introducing Dr. Hyman Muss because you're right next to me, who I have to say I consider a dear friend. I consider one of the medical oncologic thought leaders and champions. I consider him a mentor and a teacher, but I'm happy to consider him a friend. And Dr. Muss is a professor of medicine at the Mary Jones Hudson Distinguished Professor of Geriatric Oncology and Director of Geriatric Oncology Program at the University of North Carolina. Multiple awards, multiple trials, grants from the Breast Cancer Research Foundation. And by the way, we have Maya Biblowit here. Is she in the audience there? Could you stand up and say hello to everyone? Myra is the President Emeritus of the Breast Cancer Research Foundation. I think last count, they granted awards, I think upwards of $70 million for research that's going to help cure Drew. So there we go. Dr. Muss is one of those recipients, and we'll hear a lot more from him during the last panel so far as how we approach patients that may have comorbidities, what our research should be directed to, when do we say enough is enough, and when do we say let's move forward. And so I'm really excited about both panels. Dr. Chau, her name is recognizable around the world. She is a medical oncologist and she is one of the senior, not the old one, you're the young senior medical oncologist on the breast service at Memorial Sloan Kettering Cancer Center, has been at the forefront of HER2 research, HER2 trials, data coming to the forefront, which has saved patients like a 32-year-old that I met when I was a medical student. And I will say that she also has extended her passion to what happens after we treat our patients with all of these medications. What about the heart? How do we follow it? What should we be cognizant of? And so we're going to hear a lot more from Dr. Deng. Dr. Iyengar actually has a tunnel from Atlanta coming all the way up here to Hudson because he's basically at every single program, as well as Dr. Dang, as well as Dr. Muss and Dr. Arena. I guess that's it. You're all here all the time. Dr. Iyengar is at Emory University School of Medicine. He is now at the forefront, your co-chief, correct, of the breast medicine service in Atlanta. He's the director of survivorship services. So Tana, listen to all the survivorship that you're hearing, okay? These are people you need to speak to and develop a program for us up here. He is the director of survivorship services at the Winship Cancer Institute at Emory, and certainly a member of the Winship's Glenn Family Breast Center. But more importantly, he dives into the breast cancer cell as well as the human metabolism and look at metabolic influences, has authored, has researched obesity and its risks associated with breast cancer occurrence and recurrence. He's looked at the behavior of the cells when it comes to insulin and glucagon, and we'll talk about GLP-1s at the last panel. Hold those questions during this one, but kind of really gets it. And I think you'll all be thrilled to hear him speak. Um, all right, the guy in the middle in blue, sitting there like he owns Hudson Hall. Uh, are you wearing your pocket kerchief? Yes. Isn't it amazing? I love it. I went and bought my husband 5 pocket kerchiefs and he thought it was to wipe his brow. But Frank Arena is one of my best friends. I've known him since I was an intern. When I met him at 2 a.m. in the morning, this is pre-bell commission. We're doing 36 and 40-hour shifts straight on. And I was on the oncology ward. And at 2:30 a.m., I got tapped on the shoulder. I was startled because it was kind of quiet, except for the beeping of all the machines that everybody was hooked up on. And complimented me for the way that I was working with his patient. And when he left, I said, it's 2:30 a.m. and this physician, like all other physicians, should be in bed, but he came in to check on a patient that was just admitted, which tells you something about who Dr. Arena is. And he is a medical oncologist associated with NYU. He is head of the Arena Advocacy Foundation program in Long Island. He treats all malignancies, but I would say maybe 75% are breast. He has grant awards for research through his foundation. He is a pioneer in communication. And he just told me his book, Reflections of a Breast, and if I'd known I would have had it up here, is due for a second printing. He had gone back and researched the history of breast cancer. It is not a new disease. I think Rembrandt's Mistress was painted in 1654, but you have one that predates it, 1,000 years BC. 3,000 years BC was the first breast cancer diagnosis. So we will have Dr. Arena come back to give a lecture on his reflections of the breast. We'll buy 300 of his books and have him sign them. And just a wonderful teacher and a compassionate caregiver. What can I say about Ranjit Banwait? I know him this much, but what I do know is that he's going to carry the baton and the helm of breast cancer up in this part of the world forward. He is a board-certified internal medicine and bariatric medicine oncologist with a deep focus on breast cancer. I'm sorry. He joined NYOH just recently, about a year ago, coming from San Antonio. I had dinner with him last year prior to the CME accredited breast cancer program that I'll be hosting again next year. And I was so impressed with his depth of knowledge. And it was kind of like the old doctor who still wants to write her notes looking at artificial intelligence, and that's where it is. So looking forward to all the new roads that are going to travel with Dr. Banwait. And Rana, what can I say? I'm just so glad you're back with us. And your role actually is going to be interesting because all these 5 medical oncologists medically castrate patients all the time. And so there might be a few minutes where you could address some of that. So one of the questions, we have several questions that need to be addressed, but I'd like to be able to talk about early breast cancer as well as advanced breast cancer. What's happening today? What's happening in our world of research? How are we changing the way that we practiced even 5 years ago, even 3 years ago? And because breast cancer is so heterogeneous and it's multiple different diagnoses under one umbrella, that's called breast cancer. Let's take an estrogen positive breast cancer patient that is HER2 low or HER2 zero. She's had her surgery with Dr. Wolf or Dr. Pletus. She comes to us and she has a stage zero. She has a stage zero. Uh, what does stage zero breast cancer mean? Ranjit, can you take that?
Stage zero breast cancer. Wow, that's usually the long consultation, the longest one, because no one really understands it. But I think there's some misnomers that we first need to correct, which is that is this a precancerous state? Is this a cancerous state? Then why is it stage zero? So my consultation for what we call carcinoma in site 2, which is considered stage zero, it starts off with that. It is a cancerous state, but is not as invasive ductal carcinoma or lobular carcinoma. So I think clarifying that definition, and a lot of this is probably, as Dr. Platus had said earlier, that empowering the patient with knowledge so then they can carry forward and make the right decisions for themselves. So hearing it for maybe the second time, third time with me, um, it kind of sinks in a little bit that this is a cancerous state, but perhaps it's not the metastatic state or stage 3, stage 2. And perhaps maybe the management is a little bit different than what we would do for invasive carcinoma. So it starts off with that. And, there's a little nuances to it.
So there are several questions that I'm hoping that you'll all support in trying to answer that came through. And it's basically the same theme. Patient who was diagnosed with ductal carcinoma in situ, and it was a moderately differentiated grade 2, ER positive, totally removed, marked as negative, had radiation therapy in the setting of breast conservation. And the question that comes in is, do I need a PET scan in order to make sure that the disease is not anywhere else? Any one of you? Do I need a PET scan? Dr. T, can you order a PET scan for me?
I would say no. Sorry. I would say no. First, stage zero. There aren't many cancers that we treat with stage zero, right? So it's an anomaly in breast cancer. And a lot of scholars now, and a lot of breast cancer experts want to change the name and call it pre-cancer because it petrifies women and petrify me and the few men that get it.
Yeah, and that ductal carcinoma in situ, that carcinoma sticks out and the patient is terrified.
And it rarely ever spreads. And when it has, they're old studies, not with modern therapy. So it's a scary thing, but it's not, it's a little different. As far as a PET scan, that's to look for metastatic disease. And here, the chances are so slim. I would never recommend it. And the other thing about these scans, they're not perfect. To find a cancer, it has to be about the size of a marble or smaller. So you can have millions of cancer cells. Any of us on the panel could have it, and the PET scan is not going to show it. And then the other thing is occasionally it shows stuff that's not cancer, and everybody's panicked, like little benign tumors, little cysts in your liver, and you end up going on a wild goose chase that scares you to death, costs you thousands of dollars, and at the end, you're no better off. So I would never recommend it here in a stage zero's cancer. And maybe some of the other colleagues might want to even talk as a routine follow-up, even with an invasive breast cancer.
So let's take that one further, all right? And I will say that we have to change the name of DCIS, ductal carcinoma in situ. It causes more fear and it takes quite a bit of time to explain to a patient that those seeds never got past the soil. They never went past the soil to spread their seeds to other places. And it really is a scary thing. And drawing pictures and trying to define it, patients are often happy because they come to me after surgery with the idea that, am I going to need chemotherapy? Do I need a PET scan like this woman wrote in? Frank, please.
No, I think it's called. Can you hear me now? Good. I think everybody needs a PET scan. Everybody, you too, me too, everybody, right? Why not? In Long Island, where I come from, where more is always more, there used to be in strip malls everywhere you could see scanning places, just like, next to McDonald's, next to Target, whatever. There were these scanning places, and they were full. It's like, you had nothing better to do on Saturday afternoon, go get yourself scanned. They all closed down. They didn't close down because they, A, were not making money. They were making a fortune. B, it wasn't because they weren't finding things. They were, but they weren't finding cancer. You see, a PET scan does not equal cancer. We got to get that out in the open. It doesn't equal cancer. You're looking at the metabolism of sugar. And anything that eats sugar is going to light up. Inflamed, infected, autoimmune, inflammatory, oh yes, cancer. But it has to join that whole group. So to say to someone, you need to get a PET scan, let's go fishing. I don't see it. But it's in this consumptive type of philosophy that we have sort of come to, that more is more. We need to get more. And yet we have to look at the rationale behind everything. I just want to bring out something. What is old is new again. The original name for DCIS and LCIS was cancerous states. There was change roughly, was about in the late 1960s, early 70s. But
HAs.
yes, they changed the name. They're going to change it back because it scares the behemoths out of people. Really, your conversations with people, half of it is just to get over the word cancer. Nobody dies of DCIS. Let's make that clear. Nobody dies of LCIS. Nobody dies of ADH. The answer is it's a marker. It tells us what's happening. It gives us a clue. And you work on those clues to find the golden sombrero. It's always that. So in my mind, you don't go ahead and do PET scans on people unless you know what the heck you're looking for. It's not a fishing expedition. We're not just trying to see what we find on a Saturday morning here in Hudson. We're trying to figure out what it's supposed to be. You're supposed to know what you're doing when you're looking for something, not just find it and then I'll figure out what I got to do.
So a question came in, and I'm going to read it verbatim, and I think, Chau, you've spoken on this in the past. At one of the programs for physicians. This woman writes, based on the latest research and the continual sneaky pattern and behavior of lobular cancer, and this is something we can all explore, what types of scans detect the occurrence best, and how often should someone be getting them? How is it treated differently than ductal when it comes to monitoring? We don't know the stage here. Okay, we don't know any other details, but if you could take that.
Can you hear me? Thank you. Thank you, Maria. So lobular cancer, as our surgical colleagues spoke this morning, are tricky. I mean, they the glue, so the cells don't stick together and they line. So after surgery and radiation and therapy that we give, systemic therapy, much of it is anti-hormonal therapy, anti-estrogens, to prevent recurrence, to prevent the seeds, I call it the dust. There'd be dust in your body that could feed off of estrogen. So you get anti-estrogen, so that those cells, the dust particles die. But the question is, how do we know when there's a recurrence? That's a tricky question for, I think, breast cancer, regardless whether it's lobular or ductal. Our cancers go to what I say, the B's in the health, bone, brain, lung, liver. So how do I know if a patient has a recurrence? We actually don't know, unfortunately. We wait, we listen for symptoms very carefully. there's treatment symptoms, the menopausal symptoms, and there's cancer symptoms, and what are they like? So we're always listening for that, and maybe it's like having something in the bone hurts. The question asked by our patients said, "Can I get a scan? I get a scan of bladder cancer. I worry it's come back," and I listen to symptoms, and the patient's doing great. So I just say, I don't know what the scan is. And again, the PET scan won't be able to see it. We have a fancy scan called an FES scan that's looking for that estrogen. But if it's dormant or it's silent, these scans are going to be negative. So unfortunately, when we're following our patients, as our patients are surviving, thankfully, we're listening for symptoms. So there isn't the right scan. But if the patient becomes metastatic at some point, and we know they're metastatic because somehow we found it one way or the other through a biopsy and it showed in the patient's lobster, sometimes a PET scan might show it, sometimes, but oftentimes it doesn't. And this is where we use a special scan, the FES scan, to help us find those estrogen feeding cells to help us. But I have to go back, Maria, before we had these fancy scans, how did I monitor my patients who had lobster?
There was a wonderful paper that was written when I was a rookie about how we follow patients for recurrences. Should we be imaging everyone? Should we be obtaining tumor markers in everyone? And the bottom line with what you just said 2 minutes ago, it's listening. It's usually the patient telling us something that leads us to an interrogation, an investigation, a physical exam, but it is what the patient tells us. That's right. The number one way of being able to say, oh, let's just make sure XYZ is not going on. And nothing has really changed to up that. And in a stage 0, absolutely no imaging whatsoever. We don't have an answer there. We really don't. Stage 1 depends on the stage 1 and what other factors may be presenting. But honestly, unless somebody is a stage 3, or a node positive stage 2 of a young patient, there has to be a rationale for obtaining imaging. It just won't show up. And it's not, for me, 100% reassuring. My PET scan came back fine. I only had 2 positive lymph nodes. Nothing showed up anywhere. So I don't want chemotherapy. I don't want anti-estrogen therapy. That's not what's going to guide us in recommendations on how to increase disease-free survival. That means how long somebody will live without recurrence, and certainly overall survival, how long the patient will live, period. So we have to use some common sense. Yes, Dr. Arena.
Right? We have a new toy. We have a new toy, and that's circulating DNA. And I think...
that's the next question. Perfect.
You told me that last night ago, what the heck is circulating DNA? Does anybody know? I don't know. I'm trying to figure that out. But if I use my favorite analogy of puppy dogs and kittens, I think if everyone has had a puppy dog or kitten or know of one, you know that they shed hair. You don't see it until you take your vacuum cleaner out or your broom and say, oh yeah, they shed hair. Well, tumors shed hair. They shed DNA. And now we have an incredible tool basically on a simple blood test that costs a fortune, but it's a simple blood test. And we haven't seen the last of this. This is going to come into prime time like no other business. There's even a blood test now for looking at circulating DNA to make the diagnosis colon cancer. P.S. That's coming for lung cancer. That's coming from breast cancer. Stay tuned. But again, you have to use judgment who you even order this blood test on. It's not going to work for stage 0. It's not shedding hair. There's no hair to shed. Stage 1, if it's a stage 1, unless it's really outstanding circumstances, probably not. Stage 2, yes, if they're nodal positive, maybe we could look. I think the criteria stage 2 and 3 are, of course, stage 4. But that is going to be we're going to hone in on this. This may be the new toy in the chest that's coming out and everybody's going to scream about. And it's not an x-ray, it's not a PET scan, it's a blood test.
Although it's sobering because I have a patient with stage 4 disease, including the CNS, and Signatera was negative. So again, I think it's going to be very useful in advanced disease. I think it's not a standard of care at this time in early stage disease. It may become a standard of care. I'm enthusiastic about it being incorporated in clinical trials so we understand things better. But unless there's a full trial, peer-reviewed benefit, I'm right now using it only stage 4. What about you, Neil, at Emory?
I think that's well said. So, I think we're at a really exciting time in early breast cancer in terms of the research, both in terms of diagnostics as well as in terms of treatments. It's certainly circulating markers like ctDNA can be helpful in certain circumstances, but we're also starting to go back to the basics now that we have better tools like AI. So there are a lot of studies that are going on right now that are analyzing whether or not you can look at slide from the breast tumor that was removed from surgery and use histologic or pathologic patterns under the microscope to then predict, will that tumor respond to chemotherapy? Will a tumor respond to various molecular therapies? It has to do with the fact that we have research databases now for several years that have collected circulating tumor DNA in a variety of patients who have volunteered their blood graciously, from those patients who have stage 0 disease, where we learned that circulating tumor DNA is not helpful because of the lack of shedding, all the way to stage 4. So now we're in the sort of era where we can use these large data sets of molecular data from circulating tumor DNA, but also molecular data from the tumor itself and the slide under the microscope, and put together old technology and new technology to emerge with an even deeper understanding of how to optimally treat breast cancer. So it's very exciting right now, and the pace is just accelerating. I don't know if that answered your question.
No, but please go ahead. Yes, it does.
I just want to share an experience, I think, from a community perspective, right? So I think every other day, I'm fielding this question about ctDNA. I think in the community, patients know about this testing and they bring up this in the conversation when I'm seeing them. For example, I had a case the other day, taking care of the patient who's up here in New York for the summer months. She's from Florida. The oncologist did order ctDNA, early stage, there's no indication, it's not approved yet, but she was paying out of pocket because it's not approved by. So, I mean, look, this, ctDNA, and I look back at the historical data, it's been flat, and slowly but surely it is trending towards. A PET-CT was done, as we just discussed, possibly didn't need. Nothing was found. So she's up here in New York, and anxiety is off the roof. I have nothing to offer at this point. So I think this is a challenge in the community, and patients are asking about it. So looking forward to the research that we get.
Those challenges that we confront in the clinical room in that intimate setting are difficult, and oftentimes we may not have an answer at that moment, but it is our duty, it's our burden, it's our privilege to explore, interrogate, tease out everything that we can for that individual patient, the way we want it for our own family members, for ourselves. But we won't always have the answers. But all those questions are leading to answers. And I'm going to flip right back to you, Chau, because I remember in 1994, I was the PI on the first HER2 anti-HER2 antibody treatment in a salvage setting, single agent, when we didn't know anything about fish. That didn't even exist at that time. And since then, since understanding the particularly aggressive subtype of breast cancer. Does the audience know what HER2 is? All right, so I'm just going to do something real quickly because we have a few minutes. I'm going to take this first one right here. Okay, get ready, ladies and gentlemen. Okay, if I were to ask Dr. Rourke to raise her right arm all the way up into the air, okay, and Diane, you raise your left hand all the way up in the air. Without moving from your chairs, can you touch hands? Try. Come on, let me see some energy. They're waiting for the lunch hour. Okay. So this is a normal breast cell with normal HER2 expression on it. It's there. It's really not functional when we mature. And those proteins are on the surface, but they don't touch each other. Now, if I were to ask, I'm sorry, the light's in my eyes. Lauren, George, raise both your hands. Both. George, take the phone out of your left hand and raise it up. Mary, raise both hands. Diane, both hands. Now, can you each touch each other's hands? Now, these are excessive proteins on that cell surface of HER2. And in breast cancer, those touching hands tell all the pathways can tell the cell to multiply and never die. So that's a HER2 positive cell. Did I do okay or did I confuse you? Okay. No, it's okay. And the antibody that was first explored and first came in to the clinic arena because of advocacy groups, patients fighting for it, back in the early 1990s was Herceptin. And if Lauren and George can raise both hands, and then the gentleman with the eyeglasses had off his shirt in the second row. Yep, you. Take your hand and separate their hands. Go ahead, don't be shy. Don't let those hands touch. That's the antibody. It stops it from telling the nucleus to multiply. It's on yours.
I have nothing to say. She explained it so well. Thank you. So HER2. So that means that is there his. So I think of it as her, like her. Two means that there's a 1 and there's a 3 and there's a 4. But like Maria says, it's the raising hand. So when I try to think about it, it's like antenna on the head of the cancer. So it happens about 20% breast cancer patients. It makes the cancer grow really quickly. So I think it's an antenna. So all these antennas are sticking up and they're talking to each other, and it makes the cancer grow. It can have the estrogen receptor too, but that HER2 makes the cancer grow really quickly. So Maria was one of the PIs that she's been leading some of the key trials back in the 90s where this drug called trastuzumab Herceptin just got in the way, just elbowing. So those hands don't touch. The antenna just shut down, the cancer dies. That's the magic of this antibody. It's a chemo. It's an antibody, so it's special. And it just detaches and it goes in between other hands and it keeps on doing its work. And so the trial that led to its approval was in women with metastatic cancer. This was back in the 90s. And it led to really good response rates. And they started to add it to chemo. Back then we were using chemo because that's the tool that we had. Chemo is chemicals that kills cancer, just in non-targeted, just zapping the cancer. But here was this trial, and how you remember this, and Frank and all of us remember this, that this trial at over 400 patients who were courageous to be part of our clinical trial showed that adding Herceptin to chemo like Taxol, we still use it, and also Dermycin, we used it back then, led to just dramatic shrinkage of cancers and patients survived. That's a very good story. And our patients are still living, many are in remission, but Maria, I think, touched upon about the heart. There's an issue of the heart. And I can speak on that when the question comes, but we discovered that there were heart trouble with this drug. And it was really with the drug Adriamycin that we were using a lot. And how you led some key trials looking at Adriamycin. And it hurts the heart. It's a good cancer drug, but it hurts the heart. And so what we learned is that, HER2 is also found in heart. So in cancer, it makes the cancer grow quickly. So that's bad. But in heart, it's good. The heart repairs itself. So if heart is pre-injured, for example, if a person has heart attack or high blood pressure where the heart's been stressing for a long time and the muscle is really weakened, or the adriamycin drug hurts the heart and you don't know it until you know it, meaning the patient starts to have heart trouble with breathing. You give a drug like Herceptin gets in the way, it's blocking that HER2 it needs to be on to fix the heart. And the heart can't fix itself. This is where we find that there's heart failure in our patients when they get this drug given together with adriamycin. We learned a lot. Women were surviving this HER2 positive breast cancer, but what we learned is that we cannot give this medicine with the drug adriamycin together. So I'll just leave it at that. And that was in the 90s, led to the approval of this wonderful drug in 1998.
And certainly over time, we moved away. We're smarter, we're better, we're more proactive about marrying combinations of chemotherapy as well as targeted antibodies in a safer way. So we don't wind up with undue toxicities down the line in a curative, especially in TED. But we're also beginning to move away, and I hope I'm still around to see it. I think we will be, that we're moving away from chemotherapy and these special subtypes with antibody drug conjugates, with immunotherapy. And I have a question for both Dr. Iyengar and Dr. Muss. Immunotherapy. It's become coupled with triple negative breast cancer. And I suspect down the line we're going to see it travel its way to other subtypes as clinical data matures and we have safety and we have survival data available. Neil, can you explain to the audience what immunotherapy is? You see on television, Keytruda, lung cancer. I think it's approved now in 18 different solid tumors. Can you speak to what immunotherapy is and where we're moving with it down the line? And then I have a question for Dr. Muss.
Absolutely. So immunotherapy, of course, has revolutionized cancer therapy in general and has led to increased cure rates across several cancers. I would say in breast cancer, we're still sort of at the back end of the immunotherapy push. And that's largely because of what you brought up earlier, Maria, that breast cancer is a heterogeneous type of cancer. And some breast cancers are very immunogenic, others are not. Some are more driven by estrogen signaling, others are not. But what we've learned is that we can manipulate the immune microenvironment, that's the cancer interaction with the immune cells surrounding the tumor, to actually then take the brakes off, if you will, those immune cells so that they are attacking the cancer, trying to clear the cancer, or generating a microenvironment that's more hostile towards the tumor. And this has been incredibly successful for certain types of tumors that are really driven by evading the immune system. One of the ways that our body protects us from the development and growth of cancers through immunosurveillance, which is the ability of tissue-resident immune cells to recognize when there's a foreign cell or a dysfunctional cell that's developing and essentially to clear it. But cancers have developed ways to cloak themselves to hide from those mechanisms that our body has, those immune mechanisms. Immunotherapy removes that cloak and can allow the immune microenvironment then to do its job and to attack that cancer. Now, what we've also learned in breast cancer, and Murray mentioned triple negative breast cancer, is that immunotherapy by itself sometimes isn't enough, and we need to give tumor a push, whether that's chemotherapy or other therapies in combination with the immune therapy. We're now studying strategies to make immune therapy more effective in breast cancer. So in triple negative, it's the combination of chemotherapy with immunotherapy. In estrogen receptor positive breast cancers, immunotherapy initially was not very exciting. It wasn't very active. But what we're learning now is that in certain types of estrogen receptor positive breast cancers, those that express low levels of the estrogen receptor and may not be entirely driven by estrogen signaling, those respond very well to immune therapy as well. There are also studies that are going on to figure out how to make a tumor more immunogenic. So can we give either vaccines or other types of novel therapies to essentially alert local immune system that, hey, this is not a normal cell. This should be cleared. So those types of studies are ongoing, and we're seeing some really interesting preliminary data. We're also learning that we can use some of the tools we've been talking about, like next generation sequencing, to understand genomics of the tumor. And some tumors carry a lot of mutations. We call these high tumor mutational burden. And when that happens, when a tumor has a lot of mutation, of course, these are not the genetic mutations that you inherit or pass down. These are spontaneous mutations in the cancer cell. That generates a lot of what we call neoantigens, which are essentially proteins that should not be there. That really helps the immune system recognize that this is not a normal cell. And we can use immune therapies to then attack those tumor mutational high burden tumors. So I think what we're seeing here is a more specific use of immune therapy for very specific types of breast cancer. And as our diagnostic technology evolves to better understand what are the immune alterations in the tumor and what is the immune cell population around the tumor, I think we'll get better and better at recognizing two things. One, when can we successfully use immunotherapy in the treatment of breast cancer? And two, what are the ideal therapeutic partners with the immune therapy to enhance its effects? Because we know that immune therapy does have side effects. There are things that it can do to our immune system in general that can be harmful to our bodies. We really have to figure out what is the right scenario to use these therapies that balance those risks with benefit.
I'm glad you wrapped it up with that last sentence because, yes, these are life-changing therapies, these targeted therapies and immunotherapies. They certainly have enacted cures where we didn't see cure before, but they're not without their side effects. And it is our burden to educate our patients, our ancillary services, ourselves all the time on to pick up potential adversities when they're potentially treatable and reversible. And I guess with that, nothing comes without a side effect. Getting married doesn't come without a side effect, but we'll leave that alone. Dr. Muss and Dr. Banwait, also geriatric oncology, but Dr. Muss, I take exception to the word elderly. I think we should rephrase it to the mature adult patient. But we do see patients in their 7th and 8th decade that are diagnosed with triple negative. They're diagnosed with HER2 overexpressing breast cancer. And I'm not talking about a stage 4 setting where the disease itself is very life-threatening, as we have to do whatever we can to reverse it. But early stage 1, 2, when do we say it's not okay to treat a mature, healthy 75-plus patient versus observation? Or please, can you just speak to that?
Yeah. So, by the way, we're changing geriatric to cancer and aging. We've gotten rid of senior, all these terrible words.
Thank you.
So the
When I
challenge,
see clinical trials and they say in the 65 plus and over, there were more side effects,
yeah,
I want to shoot the board. So,
babies. Cancer is a disease of aging, and it's underappreciated in the United States that about the average age of a cancer diagnosis in this country right now is 67. So a lot of the images we see, the marketing, you never see older people in ads and everything. It just doesn't happen. So the challenge of caring for older people with cancer is really trying to figure out how any treatment we give, whether it's surgery, radiation, immune therapy, chemo, is going to interact with their other problems that they may or may not have. So a lot of the things we're doing in the United States with older people, and we really should be doing it with everybody, is assessing older people, not only for the other diseases they come in with frequently, like heart disease or lung disease, but all types of things like their social situation, their nutrition, things that really affect their life expectancy. And so the way we figure it out is we do an assessment. It's very easy to do. And we try to figure out if Mrs. Jones came in with heart disease and other problems, how much that going to affect her life in addition to the cancer now. And if it's really serious problems that are going to affect her life expectancy exclusive of the breast cancer, we may modify treatment and omit certain toxic therapies or lower the first dose to just make sure things go well, as opposed to just jumping in with normal treatment that we would give to a healthy 50-year-old. So it's a process to figure out what the other diseases, how do they figure life expectancy, and that can all be done pretty accurately now. There's a lot of great tools we have in this country to do it. And then look at these other things. Is this woman in shape to handle modern, high, perhaps high toxicity chemotherapy? And that's kind of basically how we're doing it. We're making a lot of progress. Not everybody needs everything. When we get a new drug, it may improve survival, but it's not like if you didn't get the new drug, your survival will be terrible. It's really pretty good.
We have to be careful. The implication is that 100% of our patients with that specific diagnosis is going to recur, and that's not so.
That doesn't happen.
Treating patients that never really need a treatment.
Right. So if you had a treatment where it would improve survival to 50% of women, and you have a new drug that's 60%, okay, if you add it to the old, but that drug is very toxic, and then you have a really older person with serious other diseases. For that 10% possibly with those risk of side effects, it may not be worth it. And it requires a lot of discussion. Got to get patients' input, like what do they think about it? They need to know about the side effects, and then make a shared decision that's best for the patient, not best for the oncologist, but best for the patient.
Great. First, I just want to question here. How does AI help us be more effective from a time perspective in clinic to be able to do the kinds of assessments in the mature patient that we should be doing, but do we have time to sit down and plug everything in? How can AI help us in that sense?
So I think before
about Claude today.
AI has been a game changer. I think obviously you can plug in a lot of the patient characteristics and it sets out a certain risk, right? So even before that, for example, in my clinic, and Dr. Muss in North Carolina, University of Rochester, they've done a lot of the work in geriatric oncology. For example, in my clinic, from when the patient is sitting and waiting to be called to the clinic room, I have a 3-meter walk test that I have pre-planned. And as they're walking into the room, I, elicit the help of an MA to record that time. And perhaps you can, when I was training, that one of my projects where I looked at, can I relate to peripheral neuropathy that way? So the person was walking in completely fine and on Taxol or what have you in chemotherapy. The walk is a little bit slower. I do a hand dynamometer. So, those are the things that we can do in clinic on natural, kind of setting. But AI, as you said, I think it's, for example, polypharmacy in geriatric statins, PPIs and PIs interact with a lot of the stuff that we give. So I think our calculators and AI has provided that time saving in that you can plug in all of the medications and the interactions that for whatever you're proposing in the regimen, is that interacting or not? So I think that is somewhere we can make use of that information.
Thank you. I'm going to get to you, Frank, in just a second. Just reminded me of a story when you said you watched that 3-meter walk. When I was at Memorial Sloan Kettering, my office was situated with the corridor. So the patient would have to walk down the corridor to be escorted into the exam rooms. I had 3 exam rooms next door to my office. And I had a patient who transferred to me from NYU with, she was probably close to 80 years old, widely metastatic disease to her bony skeleton. And when she came to me, she was on narcotics. And every time she would come to see me, she would ask for a refill of her narcotics. And I remember I was sitting in my office that day. It's rare that I got to sit in the office. I was always running from room to room. And I looked up and I watched her walking very gingerly toward the exam room. She had a in her step and she moved fluidly. And I went into the room and I said, you're walking terrific. She said, oh, but doctor, I heard everywhere. And I said, but I just watched you walk towards me and there wasn't one frown on her face. There wasn't any grimace. And she looked at me and you said she loved me. She said, all right, I'm going to tell you the truth. And I said, what is it? She goes, I don't have any pain. And I said, what are you doing with all the pills that you get for pain? She said, look, I'm going to say it out loud. The system in this country is such that whatever I get from Medicare, I can pay my rent, so I sell them on the corner for $30 a pill. She said, all the seniors are doing that in my neighborhood down in the East Village. And I just looked at her and I said, boy, am I in the wrong line of work? But I haven't thought of that story forever. Frank, please, you wanted to tell me.
So everything is relative, right? Back in the day when I was an oncology fellow, the disease known as Hodgkin's disease was really a killer. We were slap happy because we had this new thing called MOP. It was a combination therapy, and it was a lot better than we had before, and people were happy, but still, 20, 30% of the patients were dying and had toxicities that you wouldn't believe. And then we had a new therapy, ABDV, 12 initials. And now we're up to like 97% cure. So what was disease that was a killer is now a disease that's curable. So if I had a person come to me that was in med shape, that had Hodgkin's disease, I may well be pressing on the gas pedal a lot, saying, I can cure you. Versus, I got a combination, I'm going to put you through some hurdles here, but the likelihood is, well, I may, but I probably won't. And I think breast cancer has done such an incredible job over the last 20 years, but in the last even 5 to 10 years is amazing. So part of the idea of who gets treated, why should we treat, has to do with what we can do. If you can't do anything,
Should not do.
And what we should not do. So if you have medicines or therapies that are just really on the edge, you have to be honest. You can't give them a commercial for television. You have to say, this is what is going to happen. We have a shot, and do you want to take it? It is a conversation. It is a dialogue. And it can't be you're prescribing this only.
Tana, you knew it was going to get to you. So, all 6 of us prescribe medications, and now with new data that's come out, even in an early setting, ovarian suppressed patients with the goal of increasing survival as well as disease-free survival in patients, often not permanently, maybe for 5 years, but we do it. And in some instances, we cause ovarian suppression just with the medications that we've used in an early setting. How do you approach a patient? And I'm not going to not get to you, I promise. How do we approach a patient who come to you saying, I'm having a really tough time with vasomotor instability, hot flashes, vaginal dryness, my libido is low, and she may be a 20-year-old or a 65-year-old with estrogen positive disease now on endocrine therapies.
I think the approach, I mean, ideally, if we're seeing them early in the course, oftentimes, unfortunately, we're not, and sort of the effects are so severe that it prompted them to actually speak out. But I think the approach is multifactorial in the sense of we first try to figure out what are the systemic symptoms, what are the local symptoms, the hot flashes. There's obviously, we could skip a whole other discussion about the non-hormonal medications, and I think you'll be talking about that later. Lifestyle, absolutely. For management of the hot flashes, I think the first thing is to take a step back when patients come in like this and say that, we can treat things. There are ways that we can treat this. Hot flashes, definitely looking at lifestyle changes, non-hormonal remedies. Definitely the atrophy is really dramatic. People don't often know, or patients don't know, of all of the treatments that are out there. And so I think just coming out where they have some answers, we have an initial, treatment plan, looking at things from medication to physical therapy to mental health therapy as well. Sexual counseling and therapy is a huge component. So there's just so many things that we're going to address. It's not just looking at, doing a GYN exam and the just one specific anatomic thing. So I think hopefully we're addressing, all of these things, understanding and telling the patient that it doesn't have to be just because you have a hormone receptive, a breast cancer that, you're out of luck. There are so many things, and more talking about new treatments. I mean, yes, these are cancer-directed treatments, but now there's a lot more effective FDA-approved treatments that has been a game changer. Yeah, for sure.
Thank you. We have a question from the audience.
Yeah, we actually had two questions from the chat. Can you hear me?
Go ahead.
The first is, what are the treatment options for a HER2 low diagnosis?
Okay, I'll actually take that. Okay. HER2 low means that the arms are up in the air, but not that many of them. And it all depends on the stage. And HER2 low is something to look at in advanced age, stage 4 disease, to see if we can treat someone who may be refractory to their endocrine therapy or a chemotherapy that they might have been treated with. And there are some new antibody drug conjugates that are available today that have been very successful in the advanced setting. And we now know that we can use those anti-HER2 new antibody drug. An antibody drug conjugate means here's the antibody, and there are chemotherapy molecules attached to the antibody. When the antibody goes to separate those hands that are trying to hang on to one another, the tumor excretes an enzyme that melts the linker, and those chemotherapy molecules can kill the cell and neighboring cells. Okay? To get that, did I confuse everybody? We'll go over it during lunch. So these drugs have been found to be very effective, even in earlier settings. A drug like Enhertu that we used at the stage 4 setting for metastatic disease that was HER2 new overexpressing, now is also being used for estrogen positive HER2 lows, even some estrogen negative HER2 lows and ultra lows, and now it's coming into the earlier setting. So yes, there are treatments for HER2 low. We're looking at HER2 low right now only in the stage 4 setting. The other question?
What is the role of Signatera in testing for breast cancer recurrence? Is Signatera testing useful in the context of metastatic disease?
Sure, happy to take that. So this goes back to the conversation that we were having with regard to circulating tumor DNA, and now there are several assays that look for MRD, or minimal residual disease, which is essentially a method to test for circulating tumor DNA. And the idea is that if you've completed all of your adjuvant therapy, your chemotherapy, your hormone therapy, but perhaps there are a few lingering tumor cells that were resistant to these therapies or developed resistance to these therapies, then perhaps we can detect the presence of those cells through that tumor DNA shedding. The issue, though, is in that setting of minimal residual disease, micrometastatic disease, you can imagine you can draw 4, 5, 6, 10 vials of blood, and you might still miss very small amounts of residual disease. But fortunately, the technology is getting better and better and better. Signatera is one of the companies. There are several others to detect very small amounts of residual disease or circulating tumor DNA. You can have tests that are tumor-informed or tumor-agnostic. What that means is that we can just test for cell-free DNA, any DNA that's shed, and there are some key features that make it likely that DNA comes from a cancer cell, specific types of mutations or alterations. Or you can have a tumor-informed assay or test, which is looking at the tumor that was surgically resected from the breast, looking at its molecular makeup, what are the genetic or genomic alterations in the tumor tissue, and then looking for those alterations in the DNA you find in bloodstream. And those tend to be a little more accurate because you know that that reflects the original tumor that was removed. So the technology is getting better and better. And what you'll hear now is that there are some advocates for doing routine testing every certain number of months and so forth. But the issue is we're in a spot right now. The technology has advanced or continues to advance so rapidly, but the ideal or optimal use of that technology, we haven't caught up yet. We haven't finished the trials. The trials are ongoing to figure out what we were talking about earlier, about whether or not we should be thinking about escalating therapy. Should we continue observation? Are there other things that we can do? And there are a whole range of interventions that are being tested on clinical trials right now. There are new anti-estrogen therapies, the oral SERDs, for example. We're very soon about to have a new oral SERD, giredestrant, that will be approved in the early stage setting. That clinical trial
First time in 25 years.
First time in the 2 decades. It's remarkable. And that trial took the approach of let's just use the new drug for everyone so that we can avoid the development of resistant mutations. But there are ongoing clinical trials right now in the adjuvant setting. We're testing a switch strategy where you start with standard endocrine therapy like an aromatase inhibitor, and then later you switch to a novel oral SERD, so that if a resistance mutation develops, like an ESR1 mutation, you can overcome that with one of the new anti-estrogen therapies. So these tests can sometimes help detect those resistance mutations that are developing. But again, it really comes back down to when is the optimal time to do the test. And right now, we don't have that answer clearly just yet, but we're getting there.
Let's give a hand of applause to this incredible panel.